Good afternoon, everyone. This is Angie Carmen. I'll be your moderator for today. I'd like to welcome you to the PHSSR Research in Progress webinar series. Our topic for today is using an evidence-based framework to identify improvement measures for the New York Prevention Agenda's Promote Mental Health and Prevent Substance Abuse priority. I'd like to introduce our presenters. We have Christopher Maylahn, who is an epidemiologist in the Office of Public Health Practice of the New York State Department of Health. His principal focus in the department's prevention agenda toward the healthiest state is the state's health improvement plan. He is a member of the New York Public Health Practice-Based Research Network. We also have Priti, who is with the Office of Public Health Practice from the New York State Department of Health. She provides technical support on the department's prevention agenda to local health departments, hospitals, and their community partners. I'll turn the presentation now over to our presenters, after which we will introduce the two individuals who will provide commentary on this research and then open up to questions. I will invite you, as the presenters share their information with us, to put any of the questions that you have into the chat box, and then we will open up for questions via the phone after the speakers are finished. So Chris, I'll turn it over to you.
Very much. Yes, my name is Chris Maylahn, and I'm pleased to welcome all of you to this afternoon's webinar about measuring the impact of public health interventions to promote mental health and substance abuse in New York State. As you can see from the title, we have used an evidence-based framework to develop improvement measures for addressing the two issues that are impacting communities throughout the state and elsewhere across the country. I want to thank the University of Kentucky for inviting the New York Public Health Practice-Based Research Network to present the work of a quick strike project that we were awarded, and that's what you'll hear about today. This project was funded by the foundation, administered by the University of Kentucky, and is led by the Office of Public Health Practice in the New York State Health Department. I also want to acknowledge Sylvia Irani, the director of our Public Health Practice Office and the New York Practice-Based Research Network. The work we are presenting today could not have been done without the involvement and wisdom of a team of people representing various organizations and academic institutions, several of whom are here to share their insights about what we are learning from this project. I want to set the stage by briefly describing the New York State Prevention Agenda and the relevance of today's topic to that agenda. I don't need to tell you that mental health and substance abuse are grabbing the attention of clinicians, public health practitioners, policymakers, and families across the country. Historically, these issues have been primarily targeted in a clinical setting, but attention is now turning to the role public health and prevention can play in addressing them. We will be using Dr. Ross Brownson's framework for evidence-based public health to summarize the steps we took to better understand and tackle this issue in our state. Since our local communities are moving into the action phase, most of what you will hear about is what we are learning from interventions and measures that are actually being implemented. And finally, where are we headed from here? The New York Prevention Agenda was initiated in 2008 by then Commissioner of Health, Dr. Richard Daines, and it was guided by an ad hoc committee chaired by Dr. Joe Ivy Buford, who's the president of the New York Academy of Medicine. It is our state health improvement plan and serves as the blueprint for state and local action to improve the health of New Yorkers in 5 priority areas, as well as to reduce health disparities for racial, ethnic, disability, economic, and other groups who experience them. The plan was developed in collaboration with more than 140 organizations and identifies ways that local health departments, hospitals, and partners from health, business, education, and community sectors can work together to address them. Promoting mental health and preventing substance abuse is one of the 5 priorities in the plan. Each county had to pick 2 priorities. For the mental health and substance abuse priority, we know that substantial disparities exist in both the risk factors and the outcomes, and that evidence-based interventions are available for implementation. So here you can see, hopefully, a framework that many of you will recognize. This was developed by Dr. Ross Brownson and his colleagues at the St. Louis University. Over the last year, hospitals, local health departments, and other partners have completed the first 5 steps of this cycle and announced what they have chosen to focus on. Not surprisingly, all but one county in our state picked preventing chronic disease as one of their priorities. But next in line, picked by half the counties in New York, is to promote mental health and prevent substance abuse. And the county collaboratives are now in the process of implementing their action plans. They've gone through the first 5 steps across the state, and now we're at the sort of developing an action plan and implementation, and our focus is on the final box, the evaluating the program or policy. With that as background, I'm going to turn over the presentation to my colleague, Mrs. Priti Irani, who has done most of the heavy lifting to conduct the study.
Thank you, Chris. What I will be talking about is give you a little bit background on the prevention agenda and then go into a little bit about what we have learned so far from reviewing the reports. As Chris mentioned, the prevention agenda is a state health improvement plan, and the goal is improved health status, reduction in health disparities, and has an emphasis on prevention. It was a call to a broad range of stakeholders to collaborate at the community level to assess needs, identify priorities, plan and implement strategies for local health improvement. The prevention agenda is an integral part of state health reform, including delivery system reform incentive payment program district, which is like the Medicaid reform program for New York, and the state innovation plan. The next slide kind of tells you the broad range of partners who were involved in actually developing the prevention agenda. It included leaders from healthcare, business, academia, community-based organizations, local health departments, and other sister agencies, Office of Mental Health, and Office of Alcohol and Substance Abuse Services. And these groups are also part of an ad hoc leadership, and they're involved in monitoring how we are working on the prevention agenda. Now, this was in New York State, local health departments and nonprofit hospitals are required to submit their planning documents and their health improvement plans periodically. Local health departments every 4 years, and hospitals every 3 years. So the last comprehensive reports were submitted in 2013, and in that we found, like Chris said, chronic disease, which is the kind of beige-colored dot, the largest dot, was identified by every local health department and hospital as a collaborative priority with their partners. And then the blue dot, which is mental health and substance abuse, over here it says N equals 29. A couple of counties revised, and we have 30 counties that have identified promote mental health and prevent substance abuse as a priority. In this particular priority, there are 3 focus areas. The first relates to mental health promotion. The second, substance abuse prevention and other mental, emotional, behavioral disorder prevention. And the third is related to strengthening infrastructure and focuses on infrastructure and collaboration. And as you can see, the blue is local health departments. This is numbers. And the red is hospitals. It's pretty spread out in regards to which they identified as that they're focusing on. So, and then when we look at the reports, we also looked at who their partners were in collaborating in their planning process and the implementation process. And if you look at the last bar from the end, it's the mental health and behavioral health kind of sector. You see that they were pretty much engaged definitely with the local health departments. You see 69% of the local health departments said they were involved in planning and 60% during implementation. And hospitals said 46% of them were involved and 36% in implementation. So the purpose of the Quick Strike grant was to gain a better understanding of types of measures and interventions used currently at the local level. And we looked at the 2013 reports for this particular study. We've just got an update which we're looking at for this year from local health departments and hospitals on what they're doing. But we'll focus mostly on what we learned from the 2013 reports, and also to facilitate use of evidence-based approach. The focus of this presentation, only because we have a short amount of time, will be the assessment of measures and interventions reported. We will not have time to kind of share the literature review because we're still in process, and new reports keep coming out because this is an emerging issue, and we've not yet reached consensus. It'll probably take another 20 minutes. The hypothesis we had going in terms of measures, that was that in focus area to prevent substance abuse and behavioral disorders, measures would be specific, and there would be a mix of process, output, and outcome measures. For focus area, whoops, sorry, too much ahead. For focus area 1 and 3, we thought the measures would be less specific, and there would be more emphasis on process measures. And the reason was, and you don't have to read this, and it's really hard to read, but this is what you see. The blue circles kind of say that in focus area 1 and 3, at the state level, we really had not identified objectives because as we sat in a group, we really didn't have much data in these two areas. However, under disorder prevention, either whether it was substance abuse prevention or mental health, we did have some data that we could set state-level objectives for. So we offered a little more guidance in those areas. So the research questions we're going in there were 5, and 2 of them we'll discuss in detail at this presentation. What are the process and outcome measures currently being used at the local level, and what are the current interventions being implemented? What we won't discuss is what are the evidence-based and best practice measures, what does the literature tell us, and how do these local measures compare with best practice, and what factors enable local collaboration to use best practice. That we hope we will finish by the end of the grant. So when we looked at the measures, and you see on the left-hand side are the measures reported by local health departments. On the right-hand side by nonprofit hospitals, this is by percent with the N shown. All local health departments who identified, there were only 7 who identified measures related to mental health and to mental health promotion. The number 2, while for hospitals, it seemed to be there were some who identified output measures, process measures, and a few outcome measures. For area 2, which is behavioral disorder prevention, there seemed to be a more spread among process, output, and outcome measures. And in area 3, you see that there were more process measures, but at least a few output measures. Now you think this is great, but when we take a closer look at the measures, this is what we found, is that the concepts of mental health promotion and disorder prevention are not understood. Substance abuse prevention is better understood. For example, for mental health was identified as mental health promotion, as was several other disorder prevention. And increasing service utilization was identified as preventing disorders, which could be, but and then substance abuse prevention, people talked about changes in attitudes and perceptions and acceptance of drinking, which, anyway. So then the second one we found was outcomes are more clear when specific issues such as suicide prevention, substance abuse, tobacco use are identified. And it seemed consistent with what was being shown also on our sites. The outcomes, the number 3 finding was outcomes identified even in focus area 2, which relates to disorder prevention. They were often long-term, difficult to change, or dependent on an external agency for collection, and hence it was challenging to use this as a local level improvement measure. Example, suicide rate was used as an outcome measure at the local level. prescription drug use, and sometimes the sources were YRBS, uh, which is a state level survey instrument, and a few localities do implement it. The outcomes were not clear for when you talked about the focus area 3, which relates to strengthening infrastructure and collaboration, and often related, they talked about, referred to meetings, discussions, but there was no reference to outcome. And then the one observation we had is while behavioral health may be addressed to programs, it's just not coming through in the reports. There are parenting programs, family visitation programs, but most of these were not identified in the reports. When we looked at the interventions, almost all the interventions reported were population-based in that they were not talking about individual clients or patients. They were talking about reaching out to the community. Many interventions related to screening for disorders, getting people in for early screening, and increasing service utilization. And some actions were not explained in context of anything specific, so we didn't really know what they were working toward. So examples of interventions reported by local health departments and hospitals. In Focus Area 1, we didn't find any. In Focus Area 2, there was Promote ESPER, which is a screening and other screening tools, adopt tobacco-free policies in mental health facilities. And in Focus Area 3 examples, promote cross-system collaboration to optimize utilization and capacity of addiction services, identify key leaders to form an advisory team to work on data, training, etc. So what do they tell us? What do the reviews tell us? That our communities are very interested in working in promoting mental health and preventing substance abuse. An evidence-based framework will provide us with a discipline to understand the current status and help us develop a tangible vision. Most interventions described in the reports by local health departments and hospitals use a population approach, meaning they do want to work with the community, that they do need technical support, though, in identifying actionable process, output, and outcome measures, especially in the two focus areas, mental health promotion and infrastructure collaboration. And they do need help to get stronger or more actionable outcome measures in behavioral disorder prevention. And as we develop measures, we are looking at developing measures within the context of interventions and policies in all focus areas. And we have a team of people working on that. And we also want to identify evidence-based interventions and evidence-based policy approaches in multiple settings. And so this is kind of the steps that we're taking. We've identified the areas and scope. When I say scope of infrastructure collaboration, meaning it is such a broad issue when you talk about infrastructure collaboration. We've identified specific areas that most of our communities are working on, such as suicide prevention, tobacco, substance abuse prevention, and in addition, we're looking at a resiliency approach and also trauma-sensitive approaches. We've identified a criteria for these measures and a framework for the measures, and what we are working on right now is really clarifying what mental health promotion means and behavioral disorder means, reaching consensus on improvement measures. Then we hope to get feedback on the measures from experts and incorporate that feedback. So this is the protractor or the intervention spectrum that was put forth by IOM in 2009. We focus on the first half, that's promotion and prevention, and we do build bridges with treatment and maintenance or recovery. And what we hope to do is identify a set of process and outcome measures within the context of evidence-based interventions and evidence-informed policies. Also, because this is such a broad issue, and the language that is used in mental health and public health and substance abuse in the education sector, we seem to be saying the same things but have different terminology, that we need to crosswalk the language. We do need to get an understanding of the interventions, increased understanding of the intervention spectrum, because if most of our community members think service utilization is a key step in mental health promotion, then we're talking a different language. And we need to align the prevention agenda with treatment and recovery measures. And so we're working with our staff in district, and more recently IOM released the electronic health records measures, which has population level measures as well. So with that, that's about all I had. Well, thank you very much. And so now I'll turn it over to David Shern and for questions. How does that go?
This is Angie. If you'll let me have just a second, I'd like to share with folks a little bit about David and also about Mary. But first, thank you, Chris and Priti, for providing the presentation. We certainly appreciate the information there. David Shern is our first commentator. He is the Senior Public Health Advisor for the National Association of State Mental Health Program Directors. He's also the Senior Science Advisor and former President and CEO of Mental Health America, a national advocacy group addressing all aspects of mental health and mental illness. So David, we'll open up the presentation to you to provide some commentary.
Thanks, Angie. It's great to be with you all today, and it's been a real privilege to be involved with this project. You know, my initial reaction to the project was a real sense of encouragement to see that half of the counties in the state had identified mental health, behavioral health related areas as part of their public health planning. For me, signaled an important step forward. You know, we're kind of the victims of our own history in a way in mental health, in that the mental health agencies have traditionally had a very strong state focus and have really for the last 200 years generally focused almost exclusively on people with the most severe and disabling illnesses. And mental health conditions have been seen historically as both health conditions but also social welfare related issues because of the consistent poverty and disenfranchisement that characterizes people with mental illnesses. As such, state mental health authorities are quite often distinct from state public health authorities and have traditionally focused on treatment and treatment for the most severely mentally ill as opposed to working on prevention and mental health promotion. So seeing that these behavioral health issues are emerging in the public health sphere and seeing the increasing levels of cooperation among mental health authorities and public health authorities, for me, is extremely encouraging. But the results that Priti and Chris and our colleagues in New York State have come up with really map our history in a way, in that you know, they noted that measures of mental health promotion were not well represented at all. In fact, concepts of promoting mental health are not well understood and certainly not well measured generally. Similarly, many of the indicators that were suggested for preventing mental illnesses really were not prevention focused in as much as they were about earlier identification and intervention, which is not to say that earlier identification and intervention is unimportant, because it isn't. You know, typically in mental health, as contrasted with other areas, people from state systems haven't gotten care until they're already in stage 4 of their illness. And that clearly is not a sensible way to approach these problems, particularly as our treatment and detection technologies improve. So it's not a criticism of state mental health authorities that they're moving upstream and trying to catch people earlier. It's that they are, in doing so, they're continuing to miss the incredible possibilities of prevention. Another thing that has plagued our field is the fact that preventive interventions have their impact across many areas of state and local government. So we know, for example, that that visiting nurse programs, well done, have reduced levels of child abuse, reduced levels of public assistance dependence, reduced levels of criminal justice involvement, that other interventions, as well as the visiting nurse, I'm just using that as an example, have very important effects on academic performance, on school completion, on school behaviors. The social emotional health is a very important component related to academic performance, and many of the outcome measures that have traditionally been measured in prevention science relate to social and emotional health, as well as measures of illness such as depression and anxiety. Antisocial behaviors are known to be affected, as are prosocial behaviors, so we drive down the rates of antisocial behavior and increase the rates of prosocial behavior. And we now increasingly know that later health outcomes, cardiovascular disease, endocrine diseases, diabetes, and others, can be impacted by early life experiences and the degree to which those experiences are appropriately treated and or recognized and or the adverse consequences prevented through systematic intervention and social supports. And tobacco and substance use is an area that's also impacted. Now, in contrast to mental health, our colleagues who have operated in state substance use authorities have a much stronger prevention agenda, and that was clearly reflected in the information that Priti presented and that we reviewed, where they had much more specific intervention strategies and outcomes that were measurable and measured. What became clear to me from working with Priti on this project over the last few months is that we really, when we think about mental health prevention or mental illness prevention and mental health promotion, and continuing to move this conversation forward, it's really important for us to think of these as developmental processes. As I indicated, many of the outcome measures that we know will be impacted by preventive and promotion interventions span all of these areas of government functioning, from education to juvenile justice to health, obviously, mental health, substance use, child welfare. And our challenge, I think, is to find a platform or a context within which we can begin to integrate our efforts across these areas, which unfortunately is not a new problem. It's a problem we've been dealing with for a long time. Priti mentioned that one of the ideas that's being considered is the use of a trauma-sensitive approach. And many local communities around the country have started to adopt trauma-sensitive approaches based upon the emerging literature of the long-term consequences of the experience of trauma and toxic stress in early life. Those notions are pretty well understood. There's a greater possibility for a common vocabulary. You know, Priti and Chris also stressed the fact that part of our problem is we use different language and different concepts in talking about these issues given each of our unique perspectives and organizational climates. Something like a trauma-sensitive / resilience achieving perspective might provide a framework for us to have more fruitful conversations among the various elements of government that hold measures and have interventions that are related to improving the strength of our human capital through these systematic prevention interventions. Then our experience looking at communities trying to implement these sort of shared perspectives and approaches, that it takes some time to educate people with regard to how best to approach it and to understand how to go about operationalizing and developing those measures. So in conclusion, I think that it's very encouraging to see these issues emerging. For me, it's a huge step forward in terms of our ability to really importantly integrate our human services and impact our overall health and well-being. I think that the measures or lack thereof that we found in working with this project over the last couple of months very clearly reflect our history and our challenges. And I think it's important for us to take a kind of a developmental perspective using some sort of an organizing frame, perhaps one related to the long-term effects of trauma and the laudatory effects of resilience, to continue to work with local governments and local hospitals to really realize the strength of their vision in identifying the promotion of mental health and prevention of behavioral health disorders as keys to their overall public health agenda. Thanks.
Thank you, David. We appreciate your comments. I'll now turn over the presentation to Mary McHugh. Mary is Director of Strategic Clinical Solutions at the Division of Children and Family Services at the New York State Office of Mental Health. Mary, I'll turn it over to you.
Thank you so much. And Dave, Priti, and Chris, thank you so much. You know, I'd like to share that everything that you've said so far really resonates for us in the Office of Mental Health, because I think about we're doing very strategic initiatives in pockets around the state, and if we only do them ourselves, we're never going to reach a population level. We really need all child-serving systems, communities, whole communities working on initiatives. So when I was thinking about the 4 initiatives that we really are targeting, earlier identification and promotion, we have 37 providers throughout the state, so they're in counties, who are doing promotional campaigns on the promotion of social-emotional well-being. And I think it's important that we're saying social-emotional well-being because we have found, like common language, that mental health does not engage the consumer to want to seek support or seek help. So I love the well-being framework and the importance of understanding what does that look like. And we have been guided by that with the Robert Wood Johnson Foundation. Excellent campaign and research that they've pulled together on a document called Are the Children Well? A model and recommendations for promoting mental wellness of the nation's young people. There are 20 recommendations that come out of there, I think will really help communities and counties think through for the next 5 years of our prevention agenda, much more targeted measures, because as Priti commented on early on, we were really at a loss to find a statewide measure to promote mental health, or in this case, social-emotional well-being. But I think we now have the research through the ACEs study, the Adverse Childhood Experiences study, through neuroscience, talking about toxic stress, the social determinants of health. We can find proximal measures that will really inform, are we making a difference? Paying attention to school, paying attention to foster care, as all indicators for children at risk, that we decrease those numbers, we're going to be promoting children's social-emotional well-being. And of course, parents. Parents are key into providing supports to them in order to raise their children and to decrease the stress that is very common in parenting and working and living in communities. And of course, poverty is overarching a major stressor for families. So I wanted to say that I think the Department of Health very targeted technical assistance to counties around this topic, and that is really an excellent strategy so that the practitioners on the ground can join with their county to have the county promote work that is going on, so that the practitioners in the field get a sense that they are part of promoting and prevention, because the field is used to treating and providing treatment and maybe not feeling effective in solving that one area in a person's life. But if you join with a community with a focus on what you want to pay attention to, and if a county, 50% of our counties are interested in promoting mental health, and you join with that, I think there's going to be tremendous momentum. I almost feel like a tipping point. And the fact that health and mental health really are getting each other and realize it's connected. We impact each other. That social-emotional development for children interferes with their learning. We know it interferes with their health and leads to chronic disease if unintended to. So there's a lot we can bring together on this. It's very exciting. We have, I mentioned the early recognition screening initiative going on, which is an opportunity for us in mental health to go into the community and offer early identification and screening of social emotional delays universally. So we go into a school or a primary care setting or into an early Head Start program, and we use a screening instrument on social emotional for all the children and families if they seek it. And that could lead to more support, education to parents, a referral to a variety of community services, or actually to a clinic if treatment is indicated. So I think that is one of our promotional earlier identification and prevention efforts that are going on. We have many others supporting active promotion of interventions in schools and with families. A program called Parent Corps at NYU is doing incredible work in providing universal intervention in targeted high-needs communities in the Bronx and Queens, and doing fabulous work. I think our work with promoting the importance of parent skill building and supporting what's called New York State Parent Education Partnership is another effort that crosses systems, the Department of Health, State Ed, substance abuse, they're all part of it. But again, when I think of my lens from the state, it doesn't matter if I know of these programs, if it's not translated down to the community and the community paying attention to this is a resource, and that the county is paying attention that these are like an environmental scan of all the resources that they have in the community and what's missing, and then infusing those to promote social emotional and mental health. That's what's needed. And the technical assistance that's being offered through the Department of Health, my hope is that it's giving the tools to the county to marry the resources in the community with data collection, and then the importance of what is the story about what the data says. Because that message and why it matters is so important for communities to hear. I think often in the human services and in the mental health and substance abuse field, you do your work day in, day out, and you really don't know if you're effective or not. And it would be so helpful to know if you saw the dial move a little on progress in these huge population level needs. So I just wanted to end with one other project we're doing called Project Teach, which again supports the notion of supporting primary care physicians with helping families with children's emotional distress, possibly needing medication, and having child psychiatry consultation to primary care practices. So we go into the normative settings, schools and primary care, to support the attention to early supports in children's social emotional well-being. And we see that as absolutely essential, and it supports children's overall health and connects to all that good work that's going on. So thank you very much.
Thank you, Mary. We appreciate your comments as well. As I look right now, we do not at this moment have a question in the chat box, but we will invite you to put questions there, and we will also consider the phone lines open for questions. So if we have anyone that would like to direct a question either to our entire panel or to a specific member that presented, please feel free to do so.
Hi, this is CD from University of Kentucky at the National Recording Center, and I have a question for Priti and Chris regarding the results that you presented. So you talked about the data coming from these health improvement plans. Were they, just to clarify, were they both from the hospitals and from the local health departments?
Yes, there were 58 local health departments and 148 community service plans, which are submitted by hospitals or hospital systems. There are more than 148 hospitals, but sometimes they submit combined community service.
And so most of the prevention, I guess, strategies that were presented dealt with, you call them population-based or community-based interventions. Would that be correct?
Yes, meaning the outlook was, working with the community to get them to better understand services that were happening, or working with the community in the case of substance abuse to understand perceptions about drinking. So they were community-based, so it was not somebody sitting in a doctor's office.
Correct. Now, were you able to collect data or at least get an idea in terms of if you were to compare what's currently being done in terms of, you could say, clinical and treatment and screening activities relative to, let's say, these community or population-based interventions? Would you say that do you have any idea sort of what fraction of each, of each type of, you could say, intervention based on the data you collected?
Like, meaning, what were you thinking? Like, how many were
for
doing?
example, you have you have these type of population prevention strategies compared to some of the commentators were talking about the focus on screening and treatment in a clinical setting. Would you have any idea right now, sort of, if you were to try to compare the two types of strategies or interventions
We
based
could
on,
tell you, but
go ahead,
the screening wouldn't be, yeah, when we say screening, it wouldn't be at the clinical setting. It was getting them to do early screening. So it was kind of an outreach program. That was the intent. In terms of, we can tell you how many counties, not right now, but we have that data. We can tell you that it was a significant amount of counties, maybe even 1/3 or more, who identified screening as an activity that they were engaged in.
Okay.
But if you're looking for numbers within screening, how many people were reached out to,
yeah.
we don't have those numbers.
Okay, that's just interesting. And from based on what you've seen, since you were able to get the plans from both local health departments and hospitals, was how much, you could call them, concordance between the strategies between the local health departments and hospitals were there in terms of, their strategies that they're proposing, and how were the roles and responsibilities divided up? I mean, was there collaboration between local health departments and hospitals when it came to their health improvement plans, when it came to these mental health strategies?
Right. When they were asked to collaborate together, when a local health department, for example, said they were helping with early screening, getting people to early screening, and a hospital also said that, that would count as an alignment.
Okay.
So we can take a closer look at that particular aspect. I don't think we really looked at that much. We just know they both identified mental health, substance abuse, but the roles are often not very clear exactly what they're doing. We are just assuming that maybe the local health departments are doing the outreach or marketing and referrals, and the hospitals may be doing the intake, but that's not clearly explained. But however, when we look at the 2014 plans that were just submitted, we'll take a closer look at. I think there were a small group of hospitals that gave us a little more information, and we'll try and see if we can find a role there, a better idea of what their role is.
Yeah, I think that would be interesting to find out, both in terms of the roles and responsibilities, how they're divided up between the hospitals and the local health departments, and an indicator variable or some type of way to quantify how how aligned are the strategies between the local health departments and the hospitals are when it comes to these mental health prevention strategies. So, but good job. Thank you, Priti, for the answer.
Thank you, CB, for those questions. Anyone
This
else
is
have a
Mary.
question for our group?
This is Mary. I just wanted to comment. That was a great question, and I've been thinking that in the next round, the next prevention agenda starting in 2017, by that time, I really do think the efforts that are underway will just strengthen what we measure and what we know. So, for example, we could, in promotion of mental health, look to numbers of foster care children and the goal of decreasing that, because we know the importance of relationships and know that that would be disruptive. So we could be looking at different measures, because one of the things we did not have were good measures so that we would get that kind of feedback. Schools, children reading by 3rd grade is a great indicator that we've been addressing any of their distress younger than that and getting them ready for school through our universal pre-K, a major push going on in New York State right now. So I think we can bring more to the table when we revisit these measures and work with our county and state around really developing a community-wide understanding of what is promotion of mental health and how are we going to impact and make a difference.
Thank you. Do we have anyone else with a question?
Mary, this is Ann Kelly at the University of Kentucky. I was interested in the 37 providers you said that are working around New York State.
Mm-hmm.
Someone needs to mute their speakers. And the question is, are those individuals involved in any preliminary research to define measures or test measures as they are working on these strategic opportunities?
That is an excellent question, and at this point, those providers are located throughout the state, and there is a learning collaborative monthly over this 5-year initiative, and they're in about year 3. There's 2 target areas, and that is a minimum of 1,000 screens in your community settings, and you identify population, setting, and so forth, and then promotional campaigns. And we have found a trend of under 6. We have about 40% of providers targeting children and families under the age of 6, and a variety of community settings, and building up those partnerships and almost being technical assistance to the schools, to primary care. And they are all providers that are they're master level clinicians and social workers, and who are hired through their outpatient clinic. So there is a sense that if the need was or identified that services were needed, that relationship would be helpful to have families be seen. But what we're finding from a prevention standpoint, it is not about screening and then treatment. That's almost like a big lift. It's screening and then providing education, psychoeducation, or other community supports, not necessarily needing treatment at that particular time. If so, you would get that. Your suggestion is, are the providers looking at the screening instruments that they're using and looking at? Could you talk a little bit more about what you think will be helpful in that initiative?
Well, I was just, as I listened to this discussion, and I don't work in the mental health field, but there's so much confusion about roles and responsibilities that if those who are working in communities on well-defined initiatives could begin to develop some measures that are where roles are specifically defined, that may help in broader planning by many communities.
Mm-hmm. Yeah, I think what we're learning is in using primary care as an example, are we co-located, or is it collaborative care, or is it integrative care? It just, and I think they're all stages of growth, and not necessarily one is better than the other. It really, so much is based on a business model as well as the community need for how that works. And the consultation model that I spoke about with primary care, with child psychiatrist consultation, that seems to be another promoting mental health within the primary care practice, which then breaks down the barriers, because we absolutely see that parents are more comfortable in talking about concerns within a pediatric visit. And the stigma associated with mental illness and mental health, parents are, the fear alone to even broach it with somebody in the mental health field is negative. So rather than fight stigma, we're joining, I think joining with social emotional well-being is an excellent strategy.
And how do you think local health departments could be involved in that process or assist in that process?
You know, I think bringing the county health and mental health, which we're doing, and health and human services together, and I think Priti hit on this early on, in really almost bringing everyone bringing everyone on the same page around how this work impacts all of us, and it needs to be seamless if we're going to make a major change. So I do think the process of bringing the county leaders together and having these conversations. In November, we had Dave, who presented right before me, present to all the county mental health and health department leadership the ACEs, the adverse childhood experiences, explaining how that connects to the neuroscience and toxic stress. And that's such important information, and it can trauma-informed work across the board. So here, another topic to talk about. But we know that trauma over time and untreated leads to, early death, leads to chronic diseases, leads to many household dysfunctions, domestic violence, substance abuse, so on and so forth. So finding common ground and a common understanding of how it connects. I think of the tipping point and Malcolm Caldwell's book and saying how, when does it tip? And I really do believe Jack Shonkoff's work out of the Center for Child Development at Harvard is doing amazing work in messaging to populations so that they can hear this information. The scientists have the researchers, families themselves, children themselves. How do we tell this story so that people can hear it, integrate it, and make change in how they behave? Really, it's about children self-regulating, and all of us in the field being able to be more present to distress and understanding that impacts health. And that really helps with mental health. For us to say in mental health that it's your health that matters has been transformational, in my opinion. I've been doing this work for a long time, and I can engage parents so much better when I talk about their child's health, which includes social emotional. It's just part of the overall child's well-being. It's a really nice fit.
Thank you.
I don't know if I went off on a tangent there, but...
No, I think that provides a framework. Thanks.
And can I also just add to that, the November meeting which we had, actually it was supported by Quick Strike, which Mary mentioned, understanding what the role of the local mental hygiene staff, the local health departments is an issue. These are new partners, and they did say that we are not quite sure what our roles are. And so that is the process we are working through, and we are hoping that if we can offer a menu, say, of possible things that they could be doing, of how they can figure out where they're going, and a common language, that this will help us all in our process of trying to define our roles better. But it is an issue, a challenge that we are all wrestling with.
Those were great questions, and we appreciate our presenters and our commentators responding to those. We might have time for one more question. Is there one more that someone would like to put forward? Well, hearing none, I would like to thank Christopher Maylahn, Priti Irani, David Shern, and Mary McHugh for being with us today and providing this wonderful information. Thank you very much for your time, and for those of you who have participated with us today, I would direct your attention to the screen. You'll be able to see in the slides several upcoming PHSSR Research in Progress webinars. The next one, Wednesday, February 4th from 12 to 1 Eastern Time, is Immunization Reminders, a Comparative Effectiveness Pragmatic Trial. So we hope you can join us for that as well. Hearing no more questions, we thank you again for joining us today, and have a nice afternoon.